resistant to flow, these arteries over in the intestines are gonna dilate. So that makes the body think that its blood pressure is low, so then it sends the kidneys into a state where it's gonna vasoconstrict everything down, and that causes your body to retain water and salt, and that's how they get ascites. So there's so much extra fluid because the body thinks it has low blood pressure because the intestinal circulation is responding to this high blood pressure system and relaxing everything down so that the flow isn't so hard. But when it relaxes everything down, it tells the kidneys and the adrenal glands like, oh gosh, we need to clamp everything down again. So then the kidneys don't get as much blood flow and you get fluid accumulation all through the peritoneum. So, oh my gosh. Really? I thought it was her head. So people can actually get ascites for a bunch of reasons though. People with like advanced cancer can get ascites from malignant ascites. So a way that we diagnose that ascites is from portal hypertension is we calculate this SAG. It stands for, I should have written this, serum ascites albumin gradient. So whenever you do a paracentesis in somebody that you don't know why they're having ascites, you send albumin level from the ascites fluid and then you just compare it to the albumin level in their LFTs, and it's just a ratio. And if the ratio is higher than 1.1, that tells you it's from portal hypertension. Another way you can diagnose portal hypertension is with IR. So if you know a patient has liver disease but you don't know why, they'll want to get a biopsy of the liver. And so sometimes they can do a percutaneous biopsy where they just go straight through the skin, but really the preferred way to do it is transjugular. So just like how we put a central line in, they'll use an ultrasound to find the internal jugular vein, and then that connects to the vena cava, like the SVC, into the right atrium, and then through the right atrium you get the inferior vena cava, and that leads to the hepatic veins here. And once they're in there, they can actually take pressure measurements and diagnose a gradient. And so if the gradient's greater than like 5 millimeters of mercury between the hepatic vein circulation and the portal vein circulation, that's how you know that there's high blood pressure in the liver. Another way that this contributes to something we see all the time is the formation of varices. So if you guys have seen, we've had many patients before with like GE varices that bleed. And so why that happens is because blood flow is always going to find the easiest way to move forward. So when there's a really high pressure in the portal vein, it's going to make collaterals. So collaterals means alternative places for the blood to flow.
I'm sorry.
No, please.
Did you say greater than 5? What?
Yes.
Greater than 5 what?
Millimeters of mercury.
Okay.
Yeah, sorry. So it's going to create collateral blood flow, and that's what causes the varices. So varices are like engorged veins that particularly are in the esophagus and the stomach. And then when you still have this high pressure system, pressure in an engorged vein, it'll pop, right? And so in outpatient setting, they'll do routine like screening EGDs on these patients to find non-bleeding varices, and they'll try and band them. But what happens when they come here? They haven't been banded, right? So how do we treat those patients? Endoscopy is rule number 1, and obviously securing your airway is going to be important because blood can just obscure everything and they can be aspirating. So that's where they're going to try and band the varices. You also see us do octreotide. So remember how I said the response to this high pressure portal vein is that the intestinal circulation relaxes? The octreotide works by causing that to clamp down again. So it's stopping clamping down the blood flow to the varices. And we usually give a bolus of 50 mics and then a drip for 50 an hour. I think it's usually for like 48 to 72 hours just to help keep that down. And then whenever patients are GI bleeding, it puts their risk of translocation much higher. So they can get SBP, which is spontaneous bacterial peritonitis, when your ascites fluid gets infected. So for any patient that has bleeding varices, we should be putting them on prophylaxis for that with ceftriaxone, which I feel like is something I forget sometimes. And then who here has worked with a Blakemore drain before and knows what a Blakemore drain is? I was hoping we had one to play with. I don't know if we do anywhere.
We do in the supply room.
Oh, great.
But I've never seen it used. I just know it's there.
We don't have to do it right now because I know people have stuff to get back to, but we should pull one out if, I know sometimes they're hard to come by, so I don't want to take one that could be used for a patient.
There's only one.
Oh.
Just to give perspective, I've been an IC nurse for 14 years.
Yeah.
I had a Blakemore my very first week of orientation, never again.
Yeah. Yeah, and they'll just be random. Like
I
haven't personally put one in, but I know like Garcia did at Alex like 6 months ago, so it's possible. So if they can't band and you can't see anything and it's just a bloody mess, what do? So you intubate the patient, and then you need to literally go apply pressure, right? But how do you apply pressure? So you put this, I have a picture of it in my PowerPoint. You guys can Google it or I'll show you later, or we can play with one. But it's this giant OG tube looking thing. It's like a hose, and you shove it in, and you just kind of measure, you guesstimate kind of like you would an NG tube, like how many centimeters till I'm in the stomach. And it has 2 balloons. It has a gastric balloon, which just looks like a sphere, and then it has an esophageal balloon, which looks like a hot dog. And so you advance it, and you put air in the gastric balloon, and then you check an X-ray, because you want to see it's in the right position. And the balloon, the air bubble, should be like right below the diaphragm. And then once you have that, you just put 250 cc's of air in that balloon, which is gonna take up the whole volume of the stomach.
Here's a picture.
Yep.
Here's a picture, guys.
So you put 250 cc's in that gastric balloon of air, and it should tamponade off the bleeders in the stomach. And then there's also an esophageal balloon right above it that you will also put air in order to tamponade bleeding there. Oh, with that one you use a manometer instead of just a standard volume. So that's kind of temporizing until you can get GI or get your meds working again.
The one in Alex.
Hmm?
Is the patient survive?
I don't know actually.
Usually,
Mine didn't survive.
usually with
Yeah.
that tube, I mean, I haven't seen survival.
Yeah.
Yeah, that much, but I think
I've had
depend how early we start.
I've had a patient where we've like gotten them to stop bleeding, but then they also were just in liver failure, so like the liver failure killed them too. And then you have to there's not like a way to secure that, so sometimes they'll put football helmet on the patient and like tie traction, but you can also do it with an IV pole. And sorry, this is already getting kind of long, but I just want to talk about 2 more things. So to manage ascites, the way we should be doing it is giving patients diuretics. Once they're in the ICU, we're probably doing paracenteses on these patients, whether it's to diagnose an infection of the ascites fluid or just to like give them relief, because they can be having like 8 to 10 liters in there. So if they're failing diuresis, that's when they get an LVP, which is, you'll see that written down in some notes. It means large volume paracentesis, and it's defined as large volume if it's over 5 liters. At that point, if you're pulling out more than 5 liters, you can do that, but you might send the patient into paracentesis-induced circulatory dysfunction, which is just where you become very hypotensive because your body just experiences humongous fluid shift. So that's when we will give the patient albumin, like right after. And I always forget the dose, but it's pretty easy. So for every liter, if you're over 5 liters, for every liter you remove, you're gonna give like 6 to 8 grams of albumin. So let's say you take out 6 liters, 6 times 6 is 36, and then just round it to like the nearest albumin bottle. And then lastly, patients that are having refractory portal hypertension and continue to have bleeding varices and ascites, IR can offer a TIPS procedure. So TIPS stands for transjugular, so like you go through the IJ, intrahepatic in the liver, porto systemic shunt. Porto systemic means the portal vein compared to the vena cava. So the whole problem with portal hypertension is that there's a pressure gradient between the portal vein and your systemic circulation in the vena cava. So they will literally go in through the IJ down into the liver and put like a stent between those two to just literally create a bridge, and it relieves that high blood pressure in the liver. There's various complications that can arise from that, but really you should be doing it as soon as possible in your patients that are showing these signs. Once they get too sick, doing that can precipitate liver failure and hepatic encephalopathy, but it can be really, really helpful for those patients that are starting to declare themselves, and oftentimes that's more of an outpatient issue. So I think understanding this anatomy was really helpful for me to remember some of these pearls about these common conditions that we see, and that's really all I had prepared. Does anybody have any questions or input or experience?
I'm gonna stop it now because it's
Yeah.
okay.